So without further ado, I will introduce Brenda, who I'm sure many of you know because Brenda has over 40 years of IP&C experience, including working as an ICP at Seven Oaks Hospital, HSC, and was the previous program director for WHA IP&C. And then following that, Brenda has been working at Manitoba Health as an infection prevention control consultant and has been providing IP&C support for COVID-19 to the government and the shared health supply chain management. So she had retired from her role at Manitoba Health and Seniors Care in 2018 and was asked to come back to help out for COVID. So Brenda, I think we could go on all afternoon with your accomplishments, but I will leave it at that and thank you very much. Before we get started, okay, so Christina and Deepa have their hands up. Are those what we call legacy hands or new hands? Question? No? Okay. Brenda, the floor is yours. Thank you very much.
Can everyone see my slides?
Yes.
Okay, great. Okay, well, thank you very much for asking me to present to the long-term care IP&C program today. And as Carol has said, I have had many, many years of experience with infection prevention control, and hopefully I can provide you with some words of wisdom on outbreak management. So my plan today is basically to give you the textbook management on outbreak management. And, you know, there are lots of protocols around, and I do provide resources at the end. But this is, you know, if you were going to be taking an infection prevention control course, this is what you would be learning from the course. So hopefully I'll be able to help you with understanding what to do when there's an outbreak. So my first slide, of course, is that I have no financial interests or relationships to disclose. My objectives, hopefully by the end of the session, you will have the knowledge of preparedness for outbreaks, common outbreak management definitions, recognition of outbreaks, steps of outbreak management, and the role of IP&C in relation to outbreak management. So some general overall principles about outbreak management. So outbreaks are suspected when healthcare-associated infections, significant pathogens, or other adverse events occur above normal rates. So, I mean, we're going to be talking today about healthcare-associated infections, but, you know, you can get other adverse events that are not related to infections that can be outbreaks as well. In healthcare settings, outbreaks are usually due to lapses in infection prevention control or clinical practices, known or unknown infectious patients or residents or visitors, contaminated or defected products or devices, or colonized or infected healthcare personnel. Investigations are usually conducted in a standardized method, and so we will be going over that today. Ending of the outbreak usually involves modifying one or more of the contributing factors to the outbreak. So the goal of the outbreak investigation is to identify contributing factors to control the outbreak and prevent similar events in the future. So areas to be assessed during the outbreak, of course, the agent. Is it a virus? Is it a parasite? Is it a bacteria? Who's the host? Who's getting the disease? Certain environmental factors that might affect the agent and the opportunity for the exposure. The placement of individuals. Is equipment being used by the patient or the resident? Are there high-touch surfaces that are implicated? Or is there ventilation or issues within the HVAC system? So the factors that contribute to the development of the outbreak are usually what end it, and what you want to do, as I indicated before, is you hopefully find these factors, and then you modify. Now, I've been involved with outbreaks where we never did find the factor. They just came and went, and thank God for that. But most of the time, you do find a factor that you're going to change. So you want to identify the contributing factor and implement measures to prevent similar outbreaks in the future. So the first thing I want to talk about in regards to the steps is preparedness. So you need to be prepared for an outbreak. So the organizations need to do risk assessments. There are risk assessments out there in many protocols. The routine practices, Manitoba routine practices, and additional precautions document has a preparedness, a risk assessment. It's not specifically to do with outbreaks, but it is to do with routine practices and additional precautions. And a lot of factors in outbreaks are usually due to lapses in routine practices or additional precautions. There is also, I believe, on Workplace Health and Safety site, some workplace health and safety preparedness. So there's quite a few different kinds of risk assessments out there. So it is really important to determine, are you ready if you have an outbreak? So some of the factors you want to review are routine practices and other IP&C practices and processes, your PPE supplies or support, your laboratory supplies, what kind of laboratory support do you have, what type of administration support, because in an outbreak, you really need you really need your administration to support you. If you don't have the support, then you won't get too far. So it is really important for them to be there to support you along the way. Signage, disinfectants, hand hygiene products. If it's a vaccine preventable type of preparedness, you want to ensure that what's the immunizations? What type of education do you have? That would be for staff, that would be for patients and visitors. You have to ensure that you've got the education prepared. Communication, what kind of communication or signage or screening do you have available? What are your resources? What are your human resources? What's your visitor resources? What's your volunteer resources? As well as what's your agreements with your organizations that support you or your stakeholders, as well as assessment of the roles of the individuals that might be involved with the outbreak. So then definitions, because these are important as we engage in the outbreak preparedness and the outbreak management. So of course, very important is a case definition. And a case definition is a uniformly applied criteria, such as clinical signs and symptoms, might include some laboratory results or other diagnostic investigations like a chest x-ray if it's a specific respiratory infection where it involves types of issues within the chest. You're also maybe going to put something in there about chest x-rays. For example, the ILI case definition has some of these criteria involved. So in the outbreak investigation, also there might be limitation on time and place to reflect the scope of the suspected infection. So it might be an incubation period that you might be looking at. It might be a time period. If you were looking at hepatitis, you might be looking at, over a course of a month or so, because we do know that incubation periods can be long with those types of infections. So a cluster. So a cluster is a number of cases grouped by time and place, and it's usually greater than the expected number. And this is usually referred as a small outbreak and requires prompt investigation. So you don't wait. I mean, if you've got a cluster, then that's a warning sign that something might be going on. So you have to investigate that. And of course, an outbreak. It's an increase in the occurrence of cases of infection or disease over what is expected in a defined setting or a group in a specified time period, requires prompt investigation. There are, in some instances, standardized case definitions. Of course, with COVID, you know what a standardized case definition of an outbreak is. In some investigations, it would depend on your surveillance, and in a specific, if there was a certain significant microorganism that all of a sudden you're seeing, which you've never seen before, then you might not have a definition, but it would be a warning sign that you should start investigating that. Pseudo-outbreak. This is an increase in positive cultures without evidence of disease, usually attributed to a contaminated specimen or lab reporting inaccuracies. And I'll give you an example. When I worked at Health Science Center, we were notified over the course of about 2 weeks that we had 10 positive bronchoscopy specimens of an atypical mycobacterium that we'd never seen before. So we started to get really concerned about that, and so we did some investigation on the patients, and we found that a lot of them didn't really have clinical disease that would meet our case definition. So we also did go back into the laboratory, and the laboratory went back into what their processes were and found that they actually were contaminating these mycobacterium specimens when they were doing laboratory testing. So that's an example of a pseudo-outbreak, so it wasn't really an outbreak. A common source is an outbreak that involves intermittent or continuous exposure, usually referred as a point source outbreak. So this is an example of an outbreak of a foodborne illness. So as you can see, you have the presumed index case, and then all of a sudden you get a large amount of cases and it goes away. So that's a common source or a point source. A propagated source is an outbreak that involves transmission from person to person. For an example, sharing of needles of people that are hepatitis B virus or HIV positive, where over the course of quite a few months, you might see cases cooking along, and you might see secondary or tertiary waves. And this is an example. I've shown you an example in the bottom right of a propagated source where you're seeing cases that kind of cook along, and then you're going to see a few highs and lows, and that is a source that is a propagated source. So control measures. These are actions implemented to interrupt and reduce or eliminate the occurrence of the infection. So these are additional precautions in cohorting, and these are things that usually right at the beginning of the outbreak, when you are suspecting that there's something going on, and you've got a good idea of what you might be dealing with, you definitely want to start doing the control measures, and you would be placing people on additional precautions. You might be cohorting individuals that meet the same case definitions together, especially if you've got large amounts of individuals that are infected. And definitely, this is something that you always want to discuss with someone, or have some kind of a process that staff will know what to do when they have to put them on precautions or cohorting. Definitely, usually outbreaks involve some kind of enhanced cleaning and disinfection, increased hand hygiene. A lot of outbreaks, you have to do education. Staff need to be informed all the time, and you also usually have to expand or target your surveillance to the infection that you're dealing with as part of the outbreak. Environmental sampling might happen, and this usually is testing of residents or staff, or sometimes in some of the outbreaks that I've been involved with, we've actually had to do environmental sampling of different kinds of areas. And then this sometimes is really important to assist us in determining the potential source of the outbreak. So I'll give an example. So when I worked at Health Science Center, we were seeing infections in our kidney transplants. And these were usually kidney transplants that were fairly early post-op. And Legionella is can be a very serious infection in anybody who's severely immunosuppressed, which kidney transplants were. So unfortunately, we did have some people die, and some people did have quite severe infections of Legionella. So we did, of course, lots of the investigations, and our line listings and our analysis was coming up that these individuals appeared to be fairly early post-op, so it had to be something that was happening in the operating room or afterwards. And so what we did was we started doing investigations. We know that Legionella is a water organism, so we started doing testing of our water, and we actually found Legionella in our hopper in the recovery area. That was actually, some of our patients would be near that hopper when they would be recovering, and the hopper was actually spraying water onto these individuals, and they were acquiring Legionella. So, once we found that, then of course we eliminated and of course moved the individuals and got rid of the hopper as well. So again, those are part of your changes that you would do. A line listing is usually established to assist and guide the outbreak investigation. It documents your demographic data, your clinical risk factors, and any other contributing factors like equipment used or placement of infected individuals. An epidemic curve is a histogram that shows the distribution pattern of an outbreak, and it may assist in revealing the mode of transmission, the type of outbreak, whether it's a common source versus a propagated source, and the extent of the outbreak. So the next step is outbreak recognition. So it's very important, and of course you do surveillance as part of your work, and surveillance is really important to detect these healthcare associated infections. And so if you are doing surveillance on a regular basis, a lot of times you will see the clusters happening that you would want to investigate. Healthcare workers, in my course of work in IP&C over the years, I don't know how many times I've received phone calls from a healthcare worker. You know what, I think we have something going on in this area, and you need to come down and take a look at this. So healthcare workers are really important and do provide you with a lot of good information. Your colleagues, IP&C, ICPs, and other IP&C individuals. I mean, if they're having an outbreak at one of their sites, it is really important that they let you know so that you can keep an eye on, especially if you're getting individuals from their facilities. Looking at contaminated infected devices, sometimes that can happen, and if there are, Health Canada does release on a regular basis issues regarding infected devices and possible recalls, so this would be something that you would want to look into as well. Potential pathogens that could lead to healthcare associated infections, especially in long-term care, norovirus, or ILI. And of course, always important to know that healthcare workers also can become infected with healthcare associated infections. So all very important to know with your occupational health individuals if there are healthcare workers that might have exposures that we need to investigate in collaboration with them. So steps of the outbreak do not unfold in a linear or orderly manner. So, as I talk about them today, a lot of times you go back and rethink some of the steps. You go back and redo some of the steps. And it also depends on your outbreak. Every situation is different. Some outbreaks are quick and short and to the point. Some outbreaks carry on for months. and it's very frustrating that you think you've got the answer, and then you have to go back and restart or redo some of the steps again. They also can be divided into two sections, and I'll be talking about that. So there's usually your initial investigation, and then there's a follow-up investigation, and they have multiple components. So the initial outbreak investigation is confirming the presence of the outbreak. So the outbreak's reported, and usually a lot of times it's from surveillance or microbiology reports. So again, always important to go back to your surveillance, always important to go back to your micro records to confirm all of that. The decision to initiate the investigation may be based on the clinician's information that it exceeds the baseline, or it might be because you've got an existing outbreak protocol and there is a definition in there, and then that will key you on that there's something going on. Definitely within your program, there are supports and protocols to help you identify the outbreaks and to help you with some of the definitions that you have. At the beginning of the outbreak, it's very important to get a management team and outbreak management team and determine what your resources are for the outbreak. And again, this could be shared within your organization, within your SDO or your province or your region. For sure, definitely, infection prevention control is the key individual in regards to the management of the outbreak. You are the face and the voice of the outbreak, so very important to be involved. Occupational health, a lot of times if it involves staff, need to be involved. Your medical and laboratory support would need to be involved. Your management, your administration, you need to have the support of your management and your administration as you're dealing with your outbreak. Facility management, because a lot of times there's increased cleaning and they would need to be involved. And of course, communication, because a lot of times outbreaks get immediate attention and they need to be involved during the course of the outbreak. The verification of the diagnosis is usually on clinical and laboratory, and that is vital in the outbreak investigation. And as I indicated, going back to your case definitions is very important to verify that you might have an outbreak. And also make sure that you validate your cases, and we'll, because that is very important to go back and validate your cases according to your case definition. As well as discuss with your supports to ensure that you've got validation with your case definitions that you actually have an outbreak. You don't want to call an outbreak if there isn't one, but you also want to call an outbreak if there is an outbreak. So that's why it's very important to go back and do the validation and to discuss with your resources if you've got an outbreak or not. So the preliminary case definition, we talked about that in the definitions as well as the supports. Your case definition at the beginning should be narrow enough to focus on your efforts to look for the cases. For example, ILI would capture respiratory infections. Your diarrhea case definition would capture norovirus. But knowing that you will be going back a few times to probably change you might have to go back and change your definition depending on the outbreak. You want to alert your administration and key healthcare partners, which is critical to inform your key partners of the situation. Make sure that you're following your regional health and SDO processes to ensure that your outbreaks are being reported and are valid. Go back and review your definitions and your processes. There is some requirements for SIN-FI that you have to report, so make sure that you do that, as well as your processes for laboratory notification if you are going to be doing laboratory testing. And also along the way of your investigation is the importance of verbal or written reports. If there are requirements for verbal or written reports, make sure that you are doing that on a regular basis, whether it's to senior leadership, your IP&C support in your region, as well as to staff. Who's going to do the communication and reporting to staff? Because it is very important that staff are kept abreast of the outbreak. It's very frustrating for them if they don't know what's going on. In many of the outbreaks that I have been involved with, just even going down and doing education with them. I don't know how many times I've gone down and, spent hours going with small groups, educating them on the outbreak and what to expect and what to do. So it is very important for the staff, as well as the persons receiving care, the friends and family members, which of course would be directed by the site leadership. So literature review. So this is something that is done sometimes in outbreaks, not all the time, but especially if you're dealing with an outbreak that you're really finding difficulty in figuring out what the source might be. So it is important to go back to the literature, to review that literature, to determine, well, okay, there were a number of literature reports that had that specific organism isolated, and this is where they found that organism isolated, so it might help you to go back to find out that information. For example, when I worked at Health Science Center, we had an outbreak in our intensive. Well, we had an outbreak in some of our respiratory secretions. We were getting a specific organism that was coming into our respiratory secretions, and what we found was we weren't coming up with anything. So we did go to the literature and found that this organism was particularly indicated in use in respirators. So we then started taking a more detailed look at what was happening with the respirator. And we found out that they were actually using a specific medication that they were putting into the ventilator. And the infection prevention control practices were not what they should be. So going back to the literature was quite helpful for us to determine, to key back into where we might want to look for that specific type of issue. So it could be done. It probably won't be done by you because you might not have the access to the literature, but it might be done by someone in your regional IP&C support, or it might be done in collaboration. But a lot of times it is a good step in any investigation to go back and take a look at. There are lots of resources, Public Health Agency, CDC, IVAC Canada, and lots of health publications that you can go back and review the literature on. Case finding. So it's very important when you do have an outbreak to go and find, do you have additional cases? And so you might go back into your laboratory results and relook at your lab results again. You might go back and review your surveillance reports again, or you might discuss with staff. You might say, okay, for example, we've got an outbreak of diarrhea, and at this point we don't really know what it is. So you ask the staff, who's got diarrhea on this unit. Then you might go back and review the medical records to confirm, is it related to laxatives or is it related to something else? So staff can be very, very helpful when you are looking for the additional cases. But it always is, more than likely there are additional cases out there, so you really need to go back and take a look at those. You also might have to do additional surveillance cultures, which might be taxing at the most, but might be helpful in looking at where you might have additional cases that have been missed. So the line listing is the single most important tool in any outbreak investigation because it compiles all the information about the outbreak together. So important because it usually has the information about the case, their identifiers, signs and symptoms, date of onset, specimens, results. If depending on the type of outbreak, you might be looking at medications or specific procedures. In some of the outbreaks that I've been involved with, I even had to go back and take a look at the consults. In one of the MRSA outbreaks that I was involved with at Health Science Center, I actually found my information when I went back and reviewed all the consults because we were getting specific healthcare individuals coming to consult on some of the patients, and infection was being transmitted by those healthcare providers. So it was important to go back and review those consults, as well as what are some of the host factors that might predispose them to infection, which, as I indicated in that outbreak of Legionella, it was our transplant patients, and so they were immunosuppressed. A healthy individual might not acquire Legionella, but an individual that is immunosuppressed would definitely acquire Legionella. It can be, the line listing can be resource intensive, but it is very, very important. So, there needs to be some processes set up on how that can be done. But, you can get information from your medical record by staff interviews, patient location information. Usually at the beginning of the outbreak, you're creating a simple line list. If you have an extensive outbreak, you more than likely will go back and reevaluate that line list many different times and add more information onto it. I mean, as I've been involved in infection prevention control for a very long time, it was even before we used computers to do our line listings. And, I remember having like large, massive pieces of paper that I would form my line listings and then have to go back and add more pieces on and tape pieces on. So, I mean, that's how old I am in infection prevention control, that I have those things. But I mean, nowadays, electronic line listings are the way to go. But you definitely need to go back quite a few times sometimes to add onto your line listing. So the epidemic curve, the data from the line listing you use that data to create the epidemic curve. The shape of the curve can identify the mode of transmission, the source, the incubation period, the progression of the illness in the outbreak based on date and time, will give you the idea of when they were sick by day, week, or month. It will also give you ideas on if the outbreak is increasing or waning. So this is an example of a recurring norovirus infection, where you can see that at the beginning of October, there were a few cases, and then we saw a blip, and then we saw it quiet down again, and then we saw a blip again. And for example, I'll use an example of an epidemic curve where we had MRSA being investigated, and this is when I was at Health Science Center again, where we'd had a specific serotype of MRSA occurring about 1 every 2 months for the course of probably about 4 months. And so we knew that this was one that we'd not seen before. And so we then started doing some investigation and then starting to do some culturing of some of our other patients and staff that were affected. And all of a sudden, we had a huge outbreak of MRSA. So the epidemic curve can provide you with some good information. So another part of the outbreak is to go back and do observations of the clinical practices, because this is very important to determine if there are issues within the clinical practices that you maybe need to check on, and this would be added to your line listing for also to, if there's a specific pathogen where you might need to go and investigate. So for example, if you had aspergillus, which is an organism that is in dust, you would want to go back and ensure that if there was any construction activities happening in your areas, to go back and review the construction activities to determine what if there might be issues with that. Years ago on the D6, which is the area where they do, it's a high risk oncology unit. We were doing construction on that unit, and we had quite a few individuals infected with aspergillus. And when we went back and reviewed the construction activities, we found that there had been breaches in the construction activities, as well as some of our patients had actually gone into those areas, which they shouldn't have been going into, and had been exposed to the infection during those times that they'd gone into the areas. So you want to focus on practice patterns and workflows that would deviate from your IP&C practices, like cleaning, disinfection, wound care practices. You also might want to look at doing some audits, for example, equipment cleaning audits or PPE audits. Also, as I indicated, staff are very important to help us with, and so very important to go back and have open dialogue with them, be very transparent with them. Don't assign blame to them. Let them know that you want to know what kinds of processes are they're doing, because we want to try to find out what's causing the outbreak, as well as you might find some teachable moments during those observations where you might find that there is not compliance. And those definitely would be documented, but you would also teach the staff about the proper methods. So these are some of the questions. So do you always do the procedure this way? Are there situations that might require you to do it differently? Have you seen other people do it differently? So what are the challenges with maintaining good IP&C technique? And what procedures or medications might I be missing that might not be in the chart? Because sometimes those are things we'll pick up to key you in to where you might be looking for possible other areas for investigation. So laboratory testing, this is done to identify the contaminated source. And usually it's an aha moment that you find the specimen, you find the source that you're looking at. But sometimes it can be very time-consuming, very frustrating, and also can be very misleading if you do come up with some positive cultures that really aren't what you want. It can be very anxiety-provoking for the residents and staff, and sometimes they're negative, so it leaves questions unanswered. Definitely, if you are doing laboratory testing, it is something that you need to do in consultation with your supports to determine what needs to be done and when it needs to be done. So you don't want to go off and start doing testing on your own without some consultation. And you also want to go back to the line listings. Might be giving you ideas on where you might be focusing your laboratory testing. Might not be the first step in your outbreak investigation, depends on the outbreak that you're dealing with. And of course, we know that there, in some of the protocols, there already are requirements for laboratory testing. So you want to ensure that you are following those protocols and doing the laboratory testing that's required. So the initial control measures, of course, this is the ultimate goal to halt the outbreak. There's a variety of infection prevention control measures that you would implement during the course of the outbreak or at the beginning of the outbreak. And again, these can always change as your outbreak goes on. For example, additional precautions, dedicated equipment, enhanced cleaning, cohort-like cases together. That a lot of times, especially if you've got a lot of individuals that are infected, you will want to cohort them together, whether it's in rooms together or in areas together or staffing types of situations. Again, this is all types of things that you would want to discuss with your support to make sure that you know if you're doing the right thing. Of course, canceling resident activities, minimizing resident movement, visitor management, treatment, prophylaxis and vaccination or your signage. Always important to connect with occupational health and find out what kind of, if there's staff involved, what kind of procedures should be involved with them, as well as you want to initiate the control measures, and you're going to review them over time, and they might be changed as the outbreak goes on. The importance of education and reinforcement of all of these procedures on an ongoing basis, whether it's in-person education or paper or electronic education. Always important that they know why they are doing these procedures and when they have to be doing them. But definitely the control measures are driven by the findings from your line listings and your observations, which of course hopefully will cease the outbreak. So the follow-up investigation, so the steps in the initial investigation may need to be repeated multiple times over the course of the outbreak. Many times these initial steps are sufficient in controlling the outbreak, and the follow-up investigation is unnecessary. But there are outbreaks, as I indicated, that do go on for a long time, and you have to go back and do steps over and over again. So one of the things, of course, part of the follow-up investigation is going back and refining your case definition. As I indicated, you want to keep it fairly open at the beginning, then narrowing it down as the outbreak goes on. And again, that is something that you will do with your supports to determine if you need to narrow down your case definition as the outbreak goes on. Your methodology to continue your case finding, depending on what comes up with your monitoring or your surveillance. You might have to continue to look at cases. You might think your outbreak is over, but you want to keep on doing surveillance. And there's been many times that I've been involved in an outbreak and you think the outbreak is over. You continue to do your surveillance over the course of a month or 2 or 3, and then all of a sudden you start to see cases again. So then, of course, then you have to go back and declare an outbreak again. So this is something that can happen over the course of an extended, long outbreak. And as I indicated, regular review of the control measures, make sure that your measures are implemented, review them on an ongoing basis, review your compliance on an ongoing basis, make sure that if the compliance is suboptimal, you have to go back and make good rationale of why you need to make measures stronger and put in stronger measures. But as the outbreak begins to subside, you can reassess your control measures to determine if you can reduce some of them. But again, always important to make sure that you don't remove control measures too soon, and then you're going to see increased cases. So it's an evaluation on an ongoing basis. Ongoing surveillance, that's very important because that's going to evaluate the effectiveness of the measures and ensuring that the outbreak eventually is over. During the surveillance, of course, you're going to be looking at the pathogen, the incubation period, and the population, as well as when the outbreak is over, perform an outbreak review and evaluation to determine what are some measures that you might want to change as part of the outbreak investigation. Now, one of the things that you have to do with some outbreaks is you actually have to do what we call analytical studies. I've been involved with some outbreaks that we actually had to do analytic studies, and one of them was the Legionella outbreak that I was involved with at Health Science Center. We found that our water systems in our in Health Science Center had quite a bit of Legionella in the water. So we actually developed a Legionella surveillance system where any Legionella cases were investigated, and we had quite an extensive. It was basically almost like a research project. And we actually found over time that there were certain practices that were contributing to Legionella other than the hopper. One of them was, when individuals had respiratory therapy equipment like a mask or prongs and they would get clogged or dirty, staff would go to the sink and wash them and then put them back on the individuals. And of course, if the water was full of Legionella, then it was spraying and causing Legionella pneumonia. So we did find, and so that analytical study went on for probably about 3 or 4 years after we determined the actual outbreak of the Legionella. So that's an example. It can take a lot of resources, but it does provide good support, because what happened is that we found that we did have lots of Legionella in our water, and we actually had to bring in mitigation resources to do something with our water sources in Health Science Center. Communication. So this is really critical to the success of the outbreak. Communication within the facility, to your external stakeholders. Important to ensure, as I indicated, the staff, they need to be constantly communicated on what is happening with the outbreak, and this will also help with cooperation. The residents and families, make sure that any communication is in consultation with your facility or your SDO or your regional health authority. Facility leadership, they need to know all the time what's going on. In the outbreaks that I've been involved with, they wanted to know what was going on, because a lot of times it gets media attention as well. You definitely need the support of your facility leadership, so they need to know what's going on so that they can continue to support you. Patient safety, sometimes patient safety issues are outbreaks, so they need to know, especially if there is going to be some review by them later on, they need to know what's happening with the outbreak, and especially if it's an extensive outbreak, because they might need to go back and do some record review as well. If you have communications departments, outbreaks do attract media attention, so they must be prepared to address the issues. And of course, communicate your findings and lessons learned after the outbreak to all that you have to report to let them know the results of your outbreak. So the role of the infection prevention control individual is a very key important role in the outbreak. You review the data to determine if an outbreak is present. You also want to look at the clinical findings of the outbreak, establish the case definition, implement the control measures, notify the stakeholders and departments, and assist with direction of the collection of the laboratory specimens. So IP&C is a very, very important role, and as I said, it is the voice of the outbreak, and you need to be involved as the outbreak goes on. You have to be involved with the processes and the communication, the outbreak control strategies, directing or decision-making, probably providing direction for contact tracing, also reviewing new and clinical status on the cases, as well as doing the notification if there is any Manitoba Health notification requirements. You might need to be involved with auditing of anything to do with the practices. You might want to be monitoring the strategies and control measures, as well as, again, the reporting that is required and ongoing communication with your regional IP&C support. You will be involved with determining when the outbreak is over, as well as the notification to your site and manager on an ongoing basis. The evaluation summary is required, and finalizing your SINFI report as required. So in conclusion, very important to follow your your SDO and organization processes, important to work in collaboration with your outbreak management team. You are the face and the voice of the outbreak. So it is very, very important that you are empowered with this, to know that you are there to help them along with the outbreak and provide them the support. You're there to, important to implement the infection prevention control strategies to hopefully end the outbreak, as well as when the outbreak is over, to develop and plan what the issues have come out of, to plan for outbreaks in the future, as well as to address concerns and needs of the staff, residents, and visitors on an ongoing basis. So I thought to end this, I'd give you an outbreak scenario that I was involved with. And as Carol has indicated, I've been in infection prevention control since the 1980s, so around for a long time. So there was a Pseudomonas aeruginosa occurring in a multiple clinical specimens over the course of several months. And this was picked up by my surveillance that I was doing, by my laboratory surveillance, and the labs also had come to me and told me, we're seeing a lot of Pseudomonas around, and it seems to be in a lot of clinical specimens over the course of quite a few months. So we formed an outbreak management team. I went out and reviewed the clinical practice. Couldn't find any kind of major issues with clinical practice that might be promoting these infections in these clinical specimens. The laboratory sent the specimens away for serotyping. They identified a particular serotype in many of the specimens, but no common clinical specimen. So the outbreak management team directed me to do some environmental culturing. So I actually went out and I cultured the liquids used in the hospital, especially on the areas where the clinical specimens had been implicated, and found that the liquid hand soap had cultured positive for the same serotype of the Pseudomonas that we were seeing in these clinical specimens. At that time, back in the 80s, there was no single use of soap containers. It was being, I went back and I did the literature review. I went back and reviewed the filling of the bottles and the cleaning and disinfection of the soap containers. And at that time, it was being done in our housekeeping or environmental services area. And definitely their IP&C practices were not being followed. So the end of the outbreak and the recommendation of the outbreak was the decision. Sure, I'm going to be done in 1 minute. Decision to purchase single-use soap containers, and the outbreak ended at that time. So just the rest of the rest of my slides are resources, and I will share my slides with you on some outbreak management resources that you can refer to. So right now, I'll entertain any questions if anybody has anything. Thank you, Chantel.
Anybody have any questions for Brenda?
Thank you, Lisa.
Brenda, I'll throw one out. Given all the experience you've had, what has surprised you the most, just from your vantage point over at Manitoba Health with COVID? Is there anything there that jumped out at you or surprised you in any way?
And this is in relation to outbreak management or just in general?
Mm-hmm. Just like outbreak management, just on the theme, like this is an unprecedented event, right?
I know, yeah. And you know what I mean? I think for me, because I've been around for a very long time, I've been planning for this pandemic all my life, infection control life. And I think for me, and you know, I've been involved with planning at the national level for the pandemic plans. And I think that what surprised me the most was that it's gone on for such a long time. I think, you know, I think when we put these plans in place, you know, because we never dealt with it for 100 and some years, right? That has been, I think, the surprising has been how long it's gone on, but also just that everybody is they're all in the common goal of trying to end this outbreak. So yeah, I think just that it keeps on going on, and but that everyone's there trying to work hard to try to reduce the infections. So, and I'm glad to be part of it. I mean, when I was asked to come back last spring, I mean, I had been chomping at the bit. My husband knew that I was chomping at the bit. So when I got phoned to ask if I would be interested, I said definitely, and I'm still glad to be here helping out.
Excellent. Well, thanks for all the work you're doing there, particularly keeping the folks straight on PPE supplies and the like, and the guidance and direction at that provincial level. So that's great. Anybody have any specific questions for Brenda? I see lots of appreciation in the chat, and I echo that. I can't thank you enough, Brenda, for sharing your experience, and really I think all the presentations are flowing really nicely together. Okay, I see Louise, go for it. Louise, you're on mute. Oh, wrong button. You're on the hot seat. Ask a question now, Louise. Okay, well, thank you so much, Brenda. There may be folks, may come up with questions, if that's all right with you, just digesting and reflecting on all the great information you've shared. I think what you've really highlighted is preparedness, and that the structured process to go through, whether it's COVID or Pseudomonas or Legionella or what have you. That foundation is there. So I think the resources that you've appended to your presentation will be much appreciated. So I will pass the slide deck along.
Great. And I really, I think, we are the key role within an outbreak. And so, just accept, and I don't know how many times I would go to an area and they'd not want me to be there because they always knew that I was coming to give them bad news. But they knew that it was me, and they knew that I was coming to talk to them about that outbreak. So they always knew. And I mean, I still see colleagues of mine from Health Science Center in Seven Oaks that say, oh yeah, we never wanted to see you, but we were always very happy to have you. So, I think the importance of us knowing that we are a very key, important role in the management of the outbreaks.
Thank you very much. And I think that is an excellent segue into our next session, which is on leadership, because I think that really came through in your presentation. You're welcome to stay if you want. But thank you very much.
Okay, thank you very much. And if there's any questions, please feel free to send them on to me.
Okay, thanks so much, Brenda.
Thanks a lot. Bye-bye.
Bye.